Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening and welcome to Dialogue with a Doctor. I'm here again with my co-host Jim York. My name is Dr. Gregory Leach. Tonight we're talking to Bruce Nakfoor, Dr. Bruce Nakfoor. He's a practicing radiation oncologist with 21st Century Oncology. And we're going to be talking about...
Before we get into our subject, Doctor, just give us a little background of where you're from and medical school, how long you've been in Naples, and...
Sure. I was born in Chicago. My dad was in graduate school at Loyola. I grew up in Michigan, in Lansing, Michigan. I went to Notre Dame for my undergraduate work, then University of Michigan for my medical school, and then to Massachusetts General Hospital for my radiation oncology chief resident, and then down here in '96, the summer of '96.
Okay, well, let's just go into the subject.
So your offices, where are they located before we get to
Sure,
that?
we have an office at the Lutker Cancer Center across from Naples Community Hospital Emergency Room on 4th Avenue North. We have an office at the Commons. We have an office in East Naples on 951 near Collier Regional Medical Center.
Right.
We have an office on Immokalee near North Collier Hospital. And then we have an additional maybe 100 offices in the United States.
So you have different equipment in different offices depending
Yeah,
on...
there's some overlap. There's some unique machines in different offices. We have a CyberKnife, which treats radiosurgically at the Lutker Cancer Center. We have TrueBeam there, which is Varian's newest machine. We have that also at the Commons. We have a tomotherapy unit, which was the first rotating beam unit developed by some physicists at the University of Wisconsin in our North Naples office. Not exactly all unique machines, some overlap, but some differences as well.
So we're going to be talking about radiation oncology, which some of our viewers don't know much about at all.
Sure.
But also we're going to be talking about Calyso, which is a GPS tracking technology that enables you to do your job much better.
Makes us look
Why
good.
don't you tell us about these things?
So why don't we start with radiation? What exactly is radiation? Because I think when a patient is diagnosed with cancer, they understand surgery. Surgery is cutting something out. They can see that. They can experience that. They understand chemotherapy and that they see the medicine being either infused intravenously or taken orally, so they can get their hands around that. But radiation is often a mystery. You don't see it. You know, you lie on a table, the lights are out, and you see this sort of intimidating machine circling around you. But radiation is, of all the three cancer therapies, the one that is the most ubiquitous in that radiation is everywhere. It's solar light, it's fluorescent light, it's diagnostic x-rays, and it's, for us, therapeutic x-rays. It's all the same family of electromagnetic radiation where we just vary the wavelength. So we go from radio television waves to solar light to diagnostic x-rays to therapeutic x-rays, and all we're doing is shortening the wavelength. The shorter the wavelength for electromagnetic radiation, the more powerful that beam is. And so solar light can cause an effect at our skin surface. Diagnostic x-rays with shorter wavelength cause an effect beneath the skin surface, which allows us to see what's on the inside with a scan or an x-ray. And then therapeutic x-rays with an even shorter wavelength destroy the DNA of cells, both normal and abnormal cells. And that's how radiation works. Radiation works by typically penetrating into tissue and destroying the DNA of the cell. The cancer cell cannot replicate without an intact DNA, and therefore the cancer cell dies. Radiation is not selective for cancer cells. Radiation randomly deposits its energy in tissue, and that tissue creates, or wherever it's deposited, creates a free radical. That free radical then strikes the DNA and breaks the DNA. So it's not as if that beam of radiation sees cancer and selects it or sees normal and avoids it. That doesn't happen. What happens is that energy is deposited in tissue. The cancer cells do not possess the enzymes to repair that damage, and therefore they die. Our healthy tissues do have repair enzymes that can repair broken DNA, as long as that dose is not too much. I tell my patients, I want you to think of radiation like any other medicine. If Dr. Leach were to diagnose you with an infection and say you need antibiotics for 30 days, he doesn't give you 30 days worth of pills that you would take in one sitting, not because the infection couldn't handle it, but because the normal tissue couldn't handle it. You would be sick. Similar with radiation, I want you to think of radiation as one big pie that we divide up into daily digestible pieces, enough to kill cancer, but not so much that we overwhelm our body's ability to repair that damage. And that's how we end up with fractionation, dividing the radiation into fractions or pieces.
Can I ask you a question?
Sure.
When you divide that up into fractions, sometimes it's longer or shorter. How do you determine that?
That's a very good question. And what determines it is where are we treating and how big of an area are we treating. For example, if we're treating a small tumor in the brain, we're able to get away with either 1 to 5 treatments, big doses. So what we're doing is we're condensing 6 or 7 weeks of therapy into 3 or 4 or 5 treatments, or sometimes even 1 treatment. So in order to make that exchange where we're giving all of it in one sitting, we have to treat a very, very small area. Bigger area requires more treatments because that daily piece of radiation cannot be so large. So what often determines the protracted or shortened course of therapy is where we're treating and how big is our target.
Interesting.
It is interesting.
So once you explain that to your patients, then you just go beyond and treat. Tell us about
Correct.
that.
Well, I want my patients to understand what exactly they're getting into. I don't want them to think of radiation as a black box, because I think the more informed the patient is, the better they can understand it, the better they can ask questions, and the more at ease they're going to be with the treatment. Their understanding is of the therapy, the more comfortable they're going to be with the treatment. They're going to know what to expect, when to expect it, and therefore I think an educated patient is an empowered patient. A lot of times patients will ask me, do I need to go somewhere? Should I go somewhere? Because a lot of times I think patients are shocked with a diagnosis, they're scared with a diagnosis, they're in a small town. How do I know what I'm getting here is not what I would be getting if I were in Boston or in Baltimore or in Houston? And I always tell my patients that I want them to be on board with their treatment, be it here, be it in Boston, be it anywhere, and I'm happy to help anyone go to wherever they need to go. Because you really typically only get one shot at this. And I never want a patient to look back and say, maybe, what if, or maybe I didn't, had I just asked. And so I try to cover all of that with the patient. And if they need to go somewhere, if they need a second opinion, I not only encourage it, but I arrange for it. I want them to be on board. So after they have the idea of what is radiation, and we want to have the radiation treatment here, we then talk about where we're treating and what our options are with regards to where we're treating.
So radiation therapy has come a long way, and many patients have this concept of radiation therapy that's 15 years old, 20 years old.
Sure.
Injury to the skin,
Right.
and all of this kind. So what has changed to make
Sure.
it better?
So back when I was a resident in the mid-90s up in Boston, the way we would treat, for example, a prostate, well, the reason why, let's take a step back further, the reason why a lot of patients used to describe burns was because we didn't have a potent beam. And so the beam that we used to treat tumors did not have great skin sparing capacities or capabilities. We now have machines that don't enter the skin hot. They peak after we penetrated the skin at a certain depth. They're designed to deposit their energy at a certain depth. And so they have, for the most part, significant skin sparing capabilities. But that's from where it came. We didn't have powerful beams. And so, for example, a cobalt machine, which was sort of the mainstay of therapy in 50s, 60s, 70s, a cobalt machine, the maximum depth deposition was only a few centimeters in tissue. And so you can imagine skin reactions were very pronounced and often limiting how we delivered and how much we delivered of the treatment. But that's no longer the case. So from when I was a resident in the mid-90s, to treat a prostate cancer, we have an X-ray, We can't see the prostate. We know by a process of elimination where it lies. So we would inject dye in the bladder to demarcate the top, inject dye into the rectum, demarcate the back end. We knew the pubic bone, the bone that sits just below your bladder, marked the anterior edge. And then to mark the inferior edge, we would anesthetize the skin with one finger in the rectum, feel the apex or the bottom of the prostate, and through the skin inject a gold marker to mark or demarcate the inferior aspect of the prostate. So we would have an x-ray with contrast in the bladder, contrast in the rectum, and gold seeds at the bottom and a bone in the front, and that's where we knew the prostate was. We couldn't see it, but we knew it was in between all of those structures. But then we decided, well, we learned that we could use CAT scan to mark out the prostate. So rather than doing the sort of primitive plain x-ray planning, we could scan the patient and reconstruct the patient three-dimensionally, and that's what 3D conformal therapy was, which was an enormous step forward for us. That was great in that we now had, rather than treating a box, a rectangle, a square, we now had a target and a beam that was customized to the shape of our target. So whatever that prostate looked like, the beam coming out of the machine was shaped to that prostate. The problem was that the beam was either on or off. There was no way to go from 100% on to 0% off. It was either all or nothing. Great in the prostate, not great where the prostate was sandwiched up against the rectum or sandwiched up against the bladder. That was problematic. And so we started throwing filters in and out of the beam to cool down an edge. So rather than having a consistent beam, we wanted an inconsistent beam, so we could go from very hot to very cool along critical structures, along the bladder, along the rectum. And that's what intensity modulation was. So the next step after three-dimensional treatment was using that treatment, but throwing filters in and out of the beam to intensity modulate. That's IMRT.
We're going to take a short break. It's interesting to hear you describe the early 90s as primitive, but when we come back, we'll find out that, relatively speaking, compared to what we have now, it seemed to be primitive.
Correct.
We'll be back after a short break.
I had been a practicing orthopedic surgeon for a number of years, and I thought that I was invincible to the multitude of medical problems I saw around me every day. Was quite shocked when I received a phone call telling me that I had cancer of the prostate.
Dr. David Spellberg of Naples Urology Associates is the local specialist in treating prostate cancer with the new CyberKnife radiation treatment.
Once I got myself together was to do as much research as I could, and what I was looking for was a treatment that would give me the least risk of complications and side effects. And that's where the CyberKnife came into the picture.
Advanced CyberKnife technology, precise. It sends just the right dose of radiation to the cancerous areas, fast. Each treatment is only 1 hour, non-invasive. This outpatient procedure has almost no side effects.
The day after my treatment, I was out playing golf, and I'm looking forward now to continuing to enjoy a long and happy and comfortable life thanks to the care of my team of doctors and to the CyberKnife procedure.
Learn more about CyberKnife and Dr. Spellberg. Call today.
Welcome back to Dialogue with the Doctor. Once again, I'm here with my co-host Jim York, and we're speaking this evening to Bruce Nakfoor, Dr. Nakfoor. He's a radiation oncologist with 21st Century Oncology. We've talked about general concept of radiation therapy. Now we're going to talk about some more advanced things today.
Correct. So as I was saying, intensity modulation is where we intentionally created an uneven dose of radiation so that we could cool part of the beam down along a critical structure, respecting the dose limits of critical structures. So another important piece of information that my patients must understand, absorb, digest is that radiation dose is determined not by tumor, but by the normal tissue in which the tumor sits. We can't take that tumor out and rate. If we could, that would be great, because then every tumor would get a super lethal dose. However, what determines the dose we go to when we treat a tumor is the normal tissue. So if I'm treating a prostate. It's the bladder and rectum that limits me. It's not the prostate that limits me, it's the bladder and rectum. So we don't want to give too much dose to the bladder, too much dose to the rectum. Not only does it cause acute problems, frequent urination, diarrhea, but also late effects, which can be seen 6 months, 12 months, 18 months after radiation is finished. So that was the purpose of throwing in these filters, to cool down the edge, not only to reduce the morbidity, but also, on the other side of it, to go higher in dose. It allowed us to go to greater doses to cure more patients with prostate cancer. The limitation with IMRT was that the prostate is a mobile target. It's a moving target. It's continually moving. It's hanging off the bottom of a big balloon. It's hanging off the front of a big balloon. For a lot of patients, the bladder and the rectum, a lot of patients can understand that the bladder expands and contracts as we fill and empty with urine.
Right.
Patients don't always get that the rectum is another holding tank. It's not just a hollow tube that's part of your colon. It's a holding tank that expands and contracts also with stool. So that prostate, which is on the front of the rectum, on the bottom of the bladder, is moving all the time in any one direction, multiple directions. So how do we accommodate for that? Well, it wasn't as if this was new information. We knew this existed. What we did in the past to account for motion was just treat a bigger area. So if you're where the prostate is on Monday, and you're where the prostate is on Tuesday, and I'm where the prostate is on Wednesday, we radiate the whole room. Therefore, we then know that we've got the prostate covered. That's great if the prostate's there, but when the prostate's there, we're getting radiated.
Right.
We're now normal tissue, bladder and rectum. So the dose to the bladder and rectum was high. So we decided, or we learned, that we could image prior to treatment. We could scan, take regular x-rays, and then even a CAT scan before treatment, a cone beam CT. The cone beam CT allows us to localize the prostate gland before treatment, and then once we're localized and lined up, we can then treat. Brilliant, which is great, and so allowed us to treat a little tighter than what we were treating before. But the problem there is that the prostate still moves. The prostate doesn't say, okay, you've got me lined up, I'll hold still for you while you radiate me. It doesn't work that way. We can't control that motion, and it does move while the beam's on. So that's where Calyso comes into place. The guys at the Seattle Prostate Institute, Tim Maid in particular, who was a big prostate brachytherapy guy, was working with some high-tech companies in Silicon Valley and in the Seattle area, and came up with the idea of implanting a transponder which could communicate with the machine.
Right.
And then the machine could see the target while the beam's on. So if there were motion while the beam's on, either the machine moves or the machine stops. With that, we could then treat even a smaller area with less margin. Less margin means less morbidity, less rectal radiation, less bladder radiation, less side effects for the patient. Patients often think side effects of radiation are only during treatment. Well, I didn't have any problems, I must be fine.
Right.
My professor at Harvard used to say that radiation leaves footprints that get bigger with time. And so it may not be for 6 months, it may not be for 12 months, it may not be for 18 months, but you can see side effects of radiation long after it's finished. And those side effects are not fixable.
What are those?
So the most common side effects, we'll talk about prostate irradiation because that's what's particular, but of course the late side effects are all site-dependent. Side effects of radiation are site-dependent. When I'm radiating a prostate, I'm not going to give a guy a sore throat, of course. Bladder bleeding, overactive bladder, rectal bleeding, tiny spider veins flowing along the anterior edge of the rectum. Those kinds of things are very difficult to fix. And so what typically happens if a patient has rectal bleeding, a gastroenterologist will go in and laser those little spider veins. But if that laser creates an ulcer, ulcer doesn't heal because the tissue is actually less vascularized after radiation, and that can become a real nuisance. So we just assume avoid that. So the overall purpose, the overall point of the Calyso is to limit normal tissue, to make it easier for the patient both during treatment as well as after treatment. And it's been shown in scientific studies that the dose delivered to the rectum and the dose delivered to the bladder is 30-40% reduced just with this active surveillance. It's analogous to someone driving a car at night with or without lights. It's analogous to a pilot flying a plane with or without vision. Again, we're asking the prostate without Calyso to hold still while we treat it. And even with some of the new machines that treat faster, the dose rate is very fast. For a couple of minutes, you'd be shocked by how much motion there can be, because we can tell the patient, hey, empty your bladder before treatment. But we can't tell a patient, don't fill it during treatment.
Right.
No one that I know can control how a ureters fill a bladder, or similarly how the rectum fills. So that little tweak in therapy has been an enormous, enormous benefit to the patient, both, again, with regards to side effects during, as well as side effects that can occur long after treatment is finished.
So that means that your treatment is more effective, comparatively speaking?
Correct. So whenever we become better at defining target and identifying target and hitting target, there are two endpoints. One, do we raise dose delivered to the target, or two, do we reduce the normal tissue morbidity? The cure rates right now with the doses delivered to the prostate for conventional course of therapy are good, very good actually, in properly selected patients. So the greater gain with Calyso is a reduction in the amount of normal tissue in the radiated field. But I think an important point has to be made with regards to patient selection. I think it's very easy for a patient to walk into an office, okay, just give me the 9 weeks of radiation and get me through this, and great, you're going to do this, you're going to do that. But there are a lot of variables involved in selecting the appropriate therapy. Do I need brachytherapy? Do I need external beam irradiation? Do I need CyberKnife therapy? Should I have surgery? And I think even though it can be confusing to the patient and sometimes offsetting to the patient, because typically when a patient walks into an office, they want to hear, hey, you're going to be okay.
Right.
I've got this under control. This is what we're going to do. They don't want to hear, hey, it's complicated, there are a lot of moving parts, there are a lot of variables that need to be considered, these are the benefits, these are the risks. You know, maybe we need to have a secondary path review. Maybe you need hormonal therapy in conjunction with radiation. For how long should the hormonal therapy be? What's your cardiovascular state? Because your hormonal therapy can affect, you know, your cardiovascular condition, can affect your sugar metabolism. Sometimes that's a lot, but I think as a physician, not just a technician who's pushing a beam, I think it's an incredible responsibility to look at that case and give the patient everything that they need to know, all the variables that need to be considered so that an informed decision can be made, because like anything else, it's easy to look good for the first couple of years, but then if a cancer comes back and the patient's had hormonal therapy for the rest of his life,
Right.
when he could have had maybe hormonal therapy up front for 6 months, 12 months, 18 months, you know, that person's going to regret not having spent more time up front investigating, deciding, you know, what needed to be done up front, even though that's less convenient. I think there's a strong emotional component that is involved whenever anyone is diagnosed with cancer. It's a shocking diagnosis. Everyone wants to hear that they're going to be okay and that this is going to be easy and that we're going to take care of it and that I don't have to do anything. But like anything else, it's often not quite like that.
I understand what you're saying about hormonal therapy, and there are several options in terms of treatment style, but are you saying that the Calyso, the GPS-guided beam treatment is the state of the art, that all prostates should be ideally?
Sure. Assuming that they meet our inclusion criteria, because like anything else, there are inclusion criteria. For Calyso, we don't want prosthetic hips, we don't want a pacemaker. Patient can't be too big as far as his abdominal girth, because the detecting tray can only measure a certain distance away from the implanted markers. But having said that, for someone who's going to lie on a table for 9 weeks of therapy, if he were a candidate, without question, is the most advanced, state-of-the-art treatment delivery system that exists. Now, some patients will think, well, I want TrueBeam. I never heard of Calyso. Well, Calyso complements TrueBeam. It's used in conjunction with. Some patients will come in and say, hey, I heard that's antiquated information, antiquated technology, that no one's using that anymore. It's like saying, well, like telling a pilot to not use radar anymore, but they hear that. But if that were the case, why would Varian, the manufacturer of all of our radiation equipment, purchase Calyso? Why would they purchase Calyso to be used with it? They own the company now. It's a great technology, and without question, it's the state-of-the-art treatment delivery system, without question.
So, in summary, just to make sure I understand and our viewers understand, what you're saying is that Calyso is a technology that really limits the dose to the normal tissues?
Correct. Calyso allows us to tighten up our radiation field. No longer are all three of us getting radiated to account for where you may be from day to day. That beam is only 3 millimeters in any one direction around that prostate gland. Beyond 3 millimeters, there's no dose, which is an enormous, enormous advancement from just over IGRT, cone beam, CT, marker splice. None of that comes close to the accuracy of Calyso. With that accuracy means less dose to normal tissue, means tighter margins, very tight margins, almost to the point where we're really not getting any dose to the rectum or bladder.
How much prostate cancer are you treating compared, in general, with radiation therapy compared to breast or others?
Well, it varies from market to market. In Naples, as you can imagine, there's a lot of breast and prostate because of the population. You go to Fort Myers and you see more lung cancer cases or more head and neck cases. Still, though, the mainstay of radiation is often prostate cancer. It certainly accounts for the biggest proportion of a single diagnosis that we treat.
And we only have a couple of minutes left, or less than 2 minutes, but we were talking to one of your associates. He was saying that prostate surgery is really going away, comparatively speaking, and there's more treatment with radiation therapy being done. Is that correct?
Well, I don't think that's untrue. I think, like anything else, selection is critical. I think the cure rates are going to be the same with surgery or radiation. What is correct is that a thorough consultation with multiple specialists is what's needed. Surgery's not right, radiation's right. What's right is what's right for that patient. And I have plenty of patients that I tell, hey, I think you're better off having surgery for something that I see on a pathology report or within the patient's chart.
Well, we want to thank you for coming this evening. We learned a lot about radiation therapy, especially for prostate cancer. And we want you to come back because I think you have more to say.
Definitely.
So, thank you for being with us this evening.
Thank you.
Come back and see us again. Yeah, that's fine.